Today's webinar is titled Targeted Machine Learning in Action in the ICU, Transforming a Curative Healthcare Model into a Preventative Service. Our speaker today is Dr. Romain Pirracchio, who is the Chief of Anesthesia and Preoperative Medicine at Zuckerberg San Francisco General Hospital and Trauma Center. He is also the Vice Chairman of the Department of Anesthesia and Perioperative Medicine at UC San Francisco and the Ronald D. Miller Professor of Anesthesia and Perioperative Care, as well as a Professor of Biostatistics. Dr. Pirracchio was mentored by Mark von der Laan and Meyer Peterson as a postdoctoral fellow at UC Berkeley and pioneers the use of targeted learning methods in critical care medicine. Romain, thank you for being with us today, and we're looking forward to your talk.
Thank you so much, Susan. Thank you for the invitation. It's really my pleasure. So, one disclosure here for the rest of the audience. I'm not a technical person, so in terms of the statistical contents here, I will essentially try to show you how we can use some of the methods that were developed by actually a lot of people at Berkeley, including and elsewhere, including Susan actually, to really try to transform the care in the ICU. And what I would like to put the emphasis on today is really the fact that there's a possibility that these techniques will actually change very much the paradigm that we have in the ICU currently towards something very different that I will try to show you today. Next slide. Thank you. Next one. So you're all, of course, aware that about this kind of dichotomization that we usually make between the two different types of health services. The one being described as curative, which is really what we call repair medicine, where we want to diagnose condition and treat some condition. And the other one, kind of on the other side of the spectrum, is really preventive medicines, where we essentially want to identify some population at risk based on early signs. Next slide. And I would say that comparing these two types of medical services, the ICU very much is a curative medicine service, in the sense that people who come to the ICU are usually sick enough to actually present severe organ dysfunction, which is really something that is already kind of in place when the patient comes to the ICU and can, of course, further deteriorate. And the goal of the ICU is to treat the underlying reason, as well as to essentially provide some organ support to try to essentially stop the process from further deteriorating the patient condition. But next slide. I think that if we kind of think ahead about the potential for machine learning, AI, and predictive analytics to change the ICU, we can very much think about a situation in the future where we would be able to predict some critical events in the ICU and therefore transform ICU care from a curative model into more of a preventive model, where essentially we would, admit the patient much earlier on in the ICU to try to observe the patient and predict whether or not organ dysfunction are likely to occur, and try to prevent them from happening rather than really treating them when they're already in place. Next slide. So I have to say that this is not a new idea. And the idea of predicting the outcome in the ICU has been there for like almost 4 decades. And believe it or not, the scores that we're using to predict ICU mortality still currently in 2021 are the ones that were developed back in the 80s or the 90s. And I'm just showing you here the 2 scores that are essentially used worldwide. One score is called the Apache score, was developed in the US and still very much used in the US. And the other score was developed actually in Europe, the SAPS-2 score, and still the one that is currently used in Europe. There's been a lot of different changes and modification of those scores over the past, again, almost 4 decades. But consistently, the results have been the same in terms of very good discrimination, but poor calibration of those scores. And again, no matter the version of those scores, the Apache 3, 4, same for the SAPS score, although the discrimination is good, they tend to really over-predict mortality in critically ill patients. Next slide. So there were a couple of reasons that were identified for those scores to not calibrate that well. Potentially the fact that mortality dropped over time, that there are some geographical disparity that were not accounted for, and also potentially the fact that some explanatory variables that were included in those scores back in the 80s or the 90s are not really that important of predictors nowadays. So next slide. One example is this update of the score that kind of goes against the three points that I just mentioned to you in terms of explaining the reason why those scores are not calibrated well. Because in this case, it was actually a geographical recalibration of the score, in this case in Italy, based on or actually on an update of the predictors, and with of course, much more recent data. So the 3 points that I just mentioned should have been taken care of in this case. And as you can see here from this calibration plot, this evolution of the SAP score still suffers some very, very poor calibration properties, and always the same again, an over prediction of mortality. So one of the kind of our first step in the journey of trying to import, so to speak, machine learning in the ICU was to essentially try to tackle the question of whether or not machine learning could actually improve the prediction of mortality in the ICU. Next slide. And that was our major assumption, essentially because most, if not all, the scores that were available back in the early 2010 when we started this first study were essentially based on logistic regression model, very simple models that did not account for the potential complexity of the interaction between the predictors. And so we wanted to use machine learning. Next slide. But as you know better than anybody else, there was already at the time a gazillion of different algorithms, machine learning algorithms that we could have used for that. And so we wanted to pick the best algorithm agnostically and essentially let the data choose the best algorithm to model that. And that's the reason why we opted for an ensemble stacking machine learning algorithm that most of you already know, which is called the superlearner, which was developed at UC Berkeley back in 2006. So next slide. The very generic description of the superlearner, and I will go quickly through that since I'm sure that you all know the principles, is that you're essentially using a library of algorithms that may contain either parametric or non-parametric models. We're using a loss function to kind of quantify the performance of each one of the algorithm, including the library. And to be honest, in our estimation of the performance of this algorithm, we're using cross-validation. So at the end of the day, the nice feature of that is that we're able to rank the algorithm based on an honest risk estimation. And the nice feature of the superlearner is that as a stacking algorithm, it will build a new hybrid meta algorithm that is essentially based on all the different algorithms that had non-zero coefficient in the library, the non-zero coefficient referring to the performance that was again evaluated based on the loss function and cross-validation. Next slide. So one of the nice property of superlearner is that it has oracle properties, which essentially means that if none of the candidate learners in the library converge at the parametric rate, then the superlearner will perform asymptotically as well as the oracle selector. But if in turn one of the candidate is a parametric model, and it turns out that this parametric model contains the truths, then the superlearner will achieve the almost parametric rate of convergence, which is a very nice property for a data adaptive algorithm. So next slide. So for those reasons, we wanted to use the superlearner to again try to predict ICU mortality at the time. Next slide. And we wanted to do that in a fair manner, and by fair I mean we didn't want to change everything at the same time, and including the covariates that we're using to predict mortality. We wanted to make the superlearner as close as possible from the SAPS2 score and the Apache score, again for the sake of comparing the modeling approach rather than the rest of the predictor. So we use some data that are made publicly available by Harvard. Those data are called MIMIC2 data. I'm sure most of you already know about this data. And again, we use the same predictors as the one used in the SAPS2 score to model ICU mortality. Next slide. And so the first kind of nice results, although it was not the primary one we're focusing on, was that discrimination was improved as compared to the SAPS-2 score, and to also another score that we're testing here, which is called the SOFA score, which is also a pretty old score. Next slide. But the most interesting part here is that when looking at the calibration, first we're able to reproduce the result that were, again, published multiple times about the poor calibration of the SAPS-2 score consistently over calibrating, or over predicting, I should say, mortality. Next slide. And the very nice result about the super learner is that in internal as well as in external validation, we're able to obtain a much better calibration of the score as compared to the SAPS-2 score. So again, here was much more of a proof of concept rather than really something that was meant to be used in practice. And the proof of concept was really to show that using a much more flexible approach to predict mortality in the ICU could actually improve the performance and the calibration of the score. Next slide. But at the same time, as a clinician, and again, I see myself essentially as a clinician before. I was like, well, it's nice to have an accurate prediction tool or for mortality. But if this nice tool gives me a prediction of an accurate prediction of the mortality risk of my patient, it's actually not very easy to integrate this information in practice and to actually, I would say, change my treatment based on that. So that's when, kind of realizing that's when we started to kind of pivot a little bit from mortality prediction towards something that would be more actionable in practice. And we started to think about outcomes that would have three different characteristics to make them really usable by the clinician in practice. The first one is that this type of outcome should be frequent intermediate outcomes, so outcome that would be observed frequently between ICU admission and ICU outcome, mortality, death, or survival, or ICU discharge. The second characteristic for this outcome to be interesting for us was that this type of outcome should be, of course, connected to mortality or survival. And the third characteristic is that this outcome should be somehow actionable. In other words, we should, if we provide the clinician with this type of outcome, the clinician should be able to use them to actually change his practice, the treatment to try to prevent the outcome from happening, and in turn to improve patient outcome. Next slide. You can go to the next slide. So luckily, there's actually a bunch of outcomes that are very frequently observed in the ICU that kind of fulfill this three criteria. And the one that I'm going to be focusing on for the next 5 minutes is the blood pressure. So blood pressure drop, what we call hypotension, or when it's severe enough, we call it shock, is one of the main, if not the main reason for ICU admission. And I would say the interesting thing about the blood pressure or hypotension is that the longer the hypotension episode and the deeper the hypotension episode, in other words, the lower the blood pressure, the worse the outcome. And this is a pretty recent study actually showing in using the same data, mimic data. And I'm sorry, the slide is not really easy to read here, but what you can take out of it is that essentially the longer here on the x-axis the hypotension episode, and the deeper the hypotension, which is coded with the color code here, pink being the lowest blood pressure, the higher the mortality at the end. That was found in this kind of general patient population in different type of ICU in mimic. Next slide. And that was also found in different very specific cases with very, very straightforward relationship, I would say, between the hypotension depth duration dose here in the x-axis and the probability of death, in this case for traumatic brain injury, which is also a very frequent reason for ICU admission. In other words, place in a situation where we could identify an outcome that would be interesting potentially to predict, to be able to offer the doctor with the ability to really be kind of a step forward in the treatment of hypertension. Next slide. So the doctors are usually are kind of used to make their own prediction, I would say, about the evolution of the blood pressure. And the reason for that is because we learn in med school that there are some very, I would say, well-defined mechanical properties that actually link the heart to the arteries and to the rest of the body, and based on a couple of parameters, we can essentially understand at least the evolution of the blood pressure based on the cardiac output and based on the resistance in the arteries. All these parameters can be actually difficult to obtain, but it's not unfeasible to obtain an estimation of each one of these parameters. And so if the patient is monitored enough, then you can kind of, apply this very basic mechanical model to try to forecast what will be the evolution of the blood pressure, which is the delta P here in this very simplistic model where it's linked to Q, which is the cardiac output, and R, which is the resistance. But in fact, next slide, people have tried to model precisely the relationship between the different organs and the relationship that actually drives the value of the blood pressure. And this is one of, actually, believe it or not, the simplest model that is used by teams who are actually working on mechanical models for the blood pressure. It's far more complicated than the very simple model I just showed you before. And so in practice, that's the reason why when we're kind of trying to predict, and there have been a couple of studies trying to evaluate that, trying to predict or forecast the evolution of the blood pressure with the parameters that we have available in the ICU, well, it's not like flipping a coin, but it's not substantially different than that, I would say. So although the doctors are used to this mental exercise to try to forecast the evolution of the blood pressure, they're not actually extremely performant at it. So that's where we're like, well, maybe here again, using the data that were available and processing them with some advanced machine learning algorithm could be useful. Next slide. So we're not, next slide, sorry. We're not the first one to think about that, and I'm just mentioning here a nice paper that was published by our colleagues from UCLA, I think 2 years ago now, where essentially they applied this kind of idea, and they tried to extract some information from the blood pressure to predict the blood pressure. So it's kind of a prediction, a learning from the blood pressure to predict the blood pressure without looking at the rest of the patient. And so they actually extracted waveforms from monitors, and they analyzed the waveforms. They reduced dimension of this waveform signal, and by waveform I mean the beat by, or the really high fidelity, very granular blood pressure signal. And so they had to reduce the dimension of the signal to 5 features that were extracted from that, and then they use a very simple logistic regression model to integrate that and to predict the blood pressure. Next slide. So it was interesting to see that, because it was one of the first algorithm that was not only published. There were actually a couple of them being published before, but this one actually made it to the market, and it's now commercialized, and it's commercialized under the name of HPI, for Hypertension Prediction Index. So and when we look at the calibration of this score, I mean, the calibration is not bad, but the only thing that was interesting to us when we look at that is the fact that here it looks like this predictor is kind of underestimating the risk of hypotension for the patient who are actually the most at risk of presenting an hypertension episode here on this calibration plot. So here you can see again the patient who will have like a high prevalence of the hypotension episode, and for those patients the curve is above this kind of diagonal line, which essentially means that the algorithm is under predicting the risk of hypertension here. So based off on that, we wanted to kind of augment the dimension of the predictors, and we wanted to integrate more than the blood pressure signal to predict the blood pressure. Next slide. And again, the idea was to kind of account for what we know from the mechanical models, where we know that the heart rate, for instance, some parameters that are reflective of the peripheral perfusion. These are all parameters that in the mechanical model have a huge impact on the blood pressure value. And so we wanted to use at least some summary of those parameters on top, of course, of the actual blood pressure signal to be able to improve the prediction of the blood pressure. So next slide. So that's what we did in this first paper. It was published last year, actually, where essentially we took again large time series of patients in the ICU coming from MIMIC, and we actually concentrated on patients with waveform signals available, and I would say even more so with patients with good quality, which is one of the things that we can discuss at the end of the talk. The quality of the data here is certainly a key thing to discuss. But for the sake of this study, we filtrated the patient with good quality signal, and we trained a super learner model to essentially learn from a bunch of baseline characteristics, several physiological signal, and some treatment characteristics too, and we trained this model to actually predict the blood pressure up to 60 minutes ahead of time. Next slide. So this is the type of time series that we're dealing with. Next slide. And what was interesting here is that, well, we actually looked at different way to reduce dimension of the signal. That's not like the most interesting results here. But what was interesting is that here, when you're looking at the AUC, there was actually a pretty good performance, of course, at 10 minutes ahead of time, but up to 30 minutes ahead of time, the performance was actually pretty good for the detection of patients who are likely to present an hypotension episode. And sorry, I didn't mention that to you before, but here, what we want to predict was not the actual blood pressure, but what really the clinician cares about, which is an hypotension episode, which is defined as a drop in the blood pressure below 90 millimeters of mercury of systolic blood pressure. So that was the binary event that we're trying to predict here. Next slide. And in terms of calibration, the calibration was not ideal, as you can see, especially in the external validation cohort. But it was promising, and so it was more of a kind of, again, a proof of concept that we're now using to work on I would say different follow-up projects that I will briefly mention to you now. Next slide. So there are two kind of orientations that we're taking in this domain of, blood pressure prediction. The first one is to try to account in the way we're learning from the data, try to account for the fact again that we know there are some very strong physiological correlation between some of the signals that we're measuring. And one of the very strong correlation is between the heart rate and the blood pressure. And when we're trying to learn from this from the signal to predict again the blood pressure, we wanted to be able to kind of take into account the fact that those two signals are extremely correlated. And so that's the reason why we wanted to to change a little bit the modeling approach and to use a deep learning model with a multitask framework by which we are actually not only focusing on one specific task, which in this case would be the blood pressure prediction, but we're rather focusing on several tasks. And here in this study, the two tasks that we're asking the learner to learn from and to be able to predict then are where the blood pressure, of course, prediction, but also the heart rate prediction, since we know that there is a close relationship between those two parameters. Next slide. And I'm just showing you some very preliminary results here. And well, those results are actually in the review currently. But this is the prediction of the actual blood pressure. So here, not only the hypotension as a binary indicator, but the actual value of the blood pressure. And you can see here that the the deep neural network model with a multitask learning approach, which is here in blue, seems to have like a pretty good calibration in terms of both in the validation set as well as in the external validation data set, which was a cohort from a completely different group here. So this looks like this looked like a promising approach in terms of, again, trying to account for the complexity of the physiological relationship by not only learning from one task, I would say in silo and separately from other different physiological parameters, but on the contrary, really leverage this physiological relationship and learn from different parameters at the same time. Next slide. And sorry, I realized I'm rushing a little bit through the slide, but I want to make sure that I go over most of the things that I wanted to show you today. The other kind of orientation that we're taking based on the initial hypertension project that we've been working on is to move towards more of a personalized prediction. And to do that, we are working on online ensemble stacking algorithm that would take streaming data from the monitor, so streaming heart rate, blood pressure, etc., from the monitor as input, and would process them in an online manner to be able to predict, again, in an online fashion, the parameter of interest. So in this case, we're still working on the blood pressure. And that would also, at the same time, not only use the streaming data in an online fashion, but also optimize the prediction for a particular individual rather than for a population. For a population. So that's where we start to investigate into the possibility again to use online learners. But at the same time, we're placed in a situation where if we're only using online algorithms, then the problem is that when a patient enters the ICU and is connected to a monitor that would have this capacity to learn online, then the algorithm would need some time to actually learn from this very patient before being able to accurately predict the blood pressure. And of course, in most cases, well, the first, I would say, hours or maybe days worth of ICU stay are actually the one that are the most at risk of presenting severe episodes of hypertension, for instance, in our patients. So we cannot really afford having an algorithm that would train slowly, I would say, until it get better at predicting for a single individual. But we really need this algorithm to be able to predict accurately from the get-go. And so that's when we started, and you can show the next slide. That's when we started to think about combining online learners with population-based learners or pooled learners or global learners that would learn at the population level. And so that's what we're working on currently. And I'm just showing you this very preliminary result. I'm sorry here, but it's just like we just add some of those results and we kind of feel excited about those. But the idea here is that we have in the Superlearner library bunch of algorithm working, either working as online algorithm, like the pink one here, the individual learner, or algorithm that actually leverage several historical patients that were made available to the Superlearner. And so the interesting thing here is that at the beginning of the ICU stay, as you can imagine, the algorithms that are weighted the most are the ones that are learning across patients from this historical data set. But a long time, as you can see here, while the individual learner is actually picking up, and here this is actually the coefficient in the overall Superlearner that is given to each one of the candidates. You can see here that the coefficient is actually increasing over time, revealing the fact that the individual learner is having better and better performance over time, it encounters more and more data from this specific patient. So this is again very preliminary, but it was very interesting as a proof of concept again to see that it seems possible to integrate two types of learner and to have an individual learner kind of taking over time to optimize the prediction at the individual level. Next slide. So, but now again, placing ourselves in the shoes of the clinician, and that's again what I'm always trying to do, even when I'm working with my research group. The very goal here, even if we predict the blood pressure or if we predict an hypotension episode, would be to essentially offer the clinician the possibility to have access to a clinical decision support or to an estimation of what would be the optimal treatment strategy to now prevent the outcome that is likely to happen based on the prediction model, prevent this outcome from happening. And that's where we're kind of pivoting from predictive analytics towards more of a prescriptive analytics framework, where we want to leverage causal inference as well as machine learning to be able to reach this goal. Next slide. So I'm going to go real quick through that. We've been working on sort of prediction, clinical decision support in many different areas in the ICUs. Initially around prediction of very difficult to diagnose diseases, and so we have like 2 or 3 different examples of difficult diagnostic for the clinician, where we actually trained superlearner algorithm to kind of augment the perception of the clinician and to get sort of a post-test probability based off on the clinician perception as well as on the algorithm predicted probability to again increase the post-test probability and to increase the confidence of the clinician in diagnosing some specific diagnostic. So here's an example of what we call an aortic injury or acute aortic syndrome, which is a very difficult diagnosis in the ICU. Next slide. This is another difficult situation, not so much a difficult diagnosis, but difficult choice to make by the emergency medical service outside the hospital in the ambulance. And this is essentially the question of whether or not they should transfer a patient who has a trauma in a level 1 versus a level 2 or level 3 trauma center based on very simple and basic parameters that the EMS is able to collect outside the hospital. Next slide. And this is another example of a difficult diagnosis in the ICU, which was a drop in the platelet and the reason for this drop. Next slide. Sorry, I'm rushing a little bit through that, but I want to make sure that we're going through to kind of the next item here, which is really where it's really the domain or the clinical scenario where we're really investing a lot to try to use machine learning and prescriptive analytics to help the clinician make the best possible decision. And this, in short, this clinical setting is what we call septic shock, which is again, as I described before, a sudden drop in the blood pressure related to a particular clinical situation, which is a severe infection. So in this case, when the patients are in septic shock, of course, there's a lot of different actions that we want to take, from controlling the infection source, giving antibiotics, and resuscitating the patients to fix the blood pressure. But for this latter part, it can actually be very difficult. And the more severe the patient, the more difficult it is to restore the blood pressure and to restore the organ perfusion. And one of the things that was tested in randomized trials over the past 20 years was the use of steroids to kind of boost I would say, the circulatory system and reach the blood pressure goal. And there's a lot of physiological reason why this would work. But the fact of the matter is that there's been several randomized control trials with very different results when it comes to the benefit or the potential harm, actually, of giving steroid in septic shock. And these conflicting results are reflected here in our, ICU guidelines, which, as you can see here in bold, are very, I would say, vague, and they say that steroids may be given to patients not responding to treatment for the blood pressure. So we're left with this may, and we don't exactly know when we should be giving them. Next slide. So I was just here summarizing some of the evidence that explains this kind of vague conclusion, and there's bunch of meta-analysis of randomized trial, pretty much all of them showing the same point estimate here. You will see it's 0.8 to 0.9 really consistently across the different meta-analysis or even randomized trial. So it looks like this point estimate is probably close to the truth if we look at the different trials, but the upper bound of the 95% confidence interval is sometimes or many times, I would say, crossing the one kind of par. Next slide. And there were two big trials that were published last year, or 2 years ago, I should say, that were much larger in sample size. And I would say that, most of the people kind of, thought initially that the sample size was the major limitation for those results, for the previous results to be more convincing. And they were considering that, the wide confidence intervals were essentially related to a lack of powers related to the sample size of the trials that were performed so far. But the two trials that were performed recently, I can actually were against this interpretation, since the two of them were extremely large in sample size, or at least for ICU population. So we're talking about several thousand patients enrolled in each one of them. And as you can see here, this study didn't show any benefit. So interestingly, the two studies that I'm showing here and in the next slide were published in the same issue of the New England Journal of Medicine, to again put some more emphasis on the difficulty to find consistent result in this area. So you can see here there was in this trial no difference. Next slide. While in another trial, again published in the same issue of the journal, there was actually a significant benefit of the steroid combination to decrease mortality at 90 days in septic shock patients. So again, very inconsistent results. Next slide. So you can go to the next slide. Thank you. So we actually thanks. So we actually started to work on this project even before the two big randomized trials that I showed you were actually published. And so at that time, our hypothesis was that a particular combination of the steroids, which is here what I'm calling hydrocortisone plus fludrocortisone, may actually be beneficial. And we kind of came to this conclusion looking deeply into each one of the single studies that were published over, again, a 20 years period. But our assumption, or our hypothesis, I should say here, was that there was probably too much heterogeneity across trials, and a lack of statistical power to be able to show any significant benefit when combining these different trials using meta-analysis. Standard meta-analysis. So what we wanted to do at this time was to be able to use the individual patient data from the major randomized trial to combine them into an individual patient data meta-analysis with the goal of being able to adjust for severity and for other covariates. And we wanted to do that by leveraging machine learning and a particular class of estimator called TMLE, which I'm sure you all know about. Next slide. So again, that's where I will be very brief because again, I'm not like a technical expert here. But what I can tell you for those of you who are not familiar with TMLE is that it's a generic class of semi-parametric estimators that have the ability to actually leverage machine learning algorithm to model some specific parts of the likelihood that are needed to actually build the final estimator. Even though you're using data adaptive technique to actually model some specific part of the likelihood, you're still able to obtain an asymptotically linear estimator at the end, which also has the nice property of being a substitution estimator and of being doubly robust. Next slide. And the double robustness in this case is very interesting because here, if the outcome regression is consistent and the treatment regression model is also consistent, then you have an efficient estimate. If the outcome regression model or the treatment regression model are consistent and the other one is not consistent, so only one of the two is, then we do have a consistent estimator, even though this estimator may not be efficient in this case. Next slide. So very briefly, I'm going to go over some of the main results here based on, again, 3 big trials that were published before the 2-1 that I just mentioned a couple of slides ago. So the nice thing is that we're able to kind of support our initial hypothesis here. And you can see here that the association between hydrocortisone and fludrocortisone as compared to the placebo was associated with a pretty significant beneficial impact on 28 days mortality. And one thing that was also nice to see here is that the steroid regimen actually counted. And that's probably one of the main reasons why there was a lot of heterogeneity that actually led to non-significant results in the first place, is because people were kind of combining all this different treatment regimen together. And you can see that next slide, when we comparing one treatment regimen, the one before, when we're comparing this treatment regimen to another treatment regimen here, then the difference is not anymore significant. Next slide. And the other thing that we wanted to explore to see whether or not there was some heterogeneity that we could learn from was a biomarker test that is meant to actually detect the sensitivity to steroids. Unfortunately, this test was not made available in all the studies, but in the 3 studies that we used for this particular project, we had access to the result of this test. And the very interesting result here, as you can see here highlighted in red, is that the people were called responders to this test. So sorry, here it's a little counterintuitive. People who are called responders are not supposed to respond to the treatment. So they're responsive to the test, but not supposed to respond to the treatment, which is exactly what we saw here, because in the responders to the test group, the treatment effect was actually in favor of the placebo, not the treatment. While if you look at the non-responders right above, you can see that for the non-responders to the test, the treatment effect was actually favoring the treatment and not the placebo. So it was kind of also a nice way to show that there is heterogeneity that can be captured with some biomarkers and some some biological tests. Next slide. So the second part of this study is actually ongoing, and we actually figured after getting this first result that we wanted to push it a little bit further before publishing that. And it took us 2 years to actually get access to all the trials on steroids that were published over the past 20 plus years. And so we now have access to 17 trials, more than 8,000 patients, and the analysis are actually completed. I cannot share them with you, unfortunately, but they are. I can say that they're pretty close to the one we obtained with the first in the first part of the study, and so I hope that the results will be published sometime soon. Next slide. So one of the last point, we're already close to the end, but I will probably go a little past 1 p.m. So the other thing that we wanted to do based off on this project on steroid is really to again move the needle a little closer to a situation where we could help the clinician take the best possible decision at the bedside for a specific patient. And that's where we wanted to leverage the theory of causality as well as machine learning to be able to come up with individualized prescription rules. Next slide. And so again, you can go to the next slide, I guess. We started off with some sort of proof of concept that was published at the end of last year, where we defined an individual treatment rule for steroid in septic shock based on some of the trials that I just mentioned to you. So we used the individual patient data and we trained the super learner to learn from the individual treatment effect. So the way we did that was using a two-step approach where we basically trained the super learner to learn from the outcome based on covariates and treatment. And then in a second step, we manipulated this prediction, this super learner fit by intervening on the treatment, setting the treatment to the counterfactual treatment for each one of the patients. In other words, if a patient received the placebo, we got, of course, the prediction from the super learner for the placebo. But we also wanted to get the prediction for the counterfactual treatment, which is the steroid treatment in this case. And so we intervened on by setting the treatment to the steroids, and we obtained this counterfactual outcome based on that. And so by comparing the two outcomes, the factual and the counterfactual outcome, we're able to obtain an estimate of the individual treatment effect. So this is just like a brief description of the performance of the super learner to predict, in this case, Y given A and W, so the outcome given the treatment and the characteristics. Next slide. But what was even more interesting is that then we tried to extrapolate this treatment rule and to see what would be the net benefit of treating patients with different treatment rules. One being based on this super learner, again, for the individual treatment effect. Another treatment rule being based only on the baseline risk, evaluated on one of the risk scores that I mentioned at the very beginning of the lecture, the SAPS-2 score, basically acknowledging that the probability of death under treatment depends on the probability of death at baseline, which is nothing more than the risk. So we accounted for the risk in the predicted outcome under the treatment. And then, so that's the gray line. And then the black and the blue lines are the treatment the treatment options that we would choose based off the results of the randomized trial. And by that I mean if the randomized trial is actually concludes that the treatment is beneficial, then this treatment will be adopted for everybody. And if a given randomized trial goes in the opposite direction, then this treatment will essentially be abandoned, which is kind of the way we as clinicians are interpreting randomized trial in most cases. And what I want to show you here is the fact that I would say it's kind of expected, but it was nice to see that, is the fact that in orange here, you can see that the net benefit expected from using an individualized treatment rule really clearly outweighs the benefit that you can expect from a treatment that is decided based upon either the result of the randomized trial or even based upon the risk stratification using the SAPS-2 score. So that was again a proof of concept that was interesting to have. Next slide. But now the kind of the follow-up work that we're doing, and we're also close to completing this one here, so I hope this one is going to be published sometime soon, is that we're adding a third step to the first two that I was mentioning to you. So remember, the first step is to train an algorithm to learn from the outcome based on the treatment and on the covariates. The second step is then to intervene on the treatment to get the individual treatment effect. But we're adding a third step to this framework where we're saying, well, we want something that is interpretable and usable by the clinician at the bedside. And this means that, first of all, we need to kind of reduce the dimension of the covariates to covariates that are actually readily available for the clinician based on either the monitor information or some basic information in the chart. So we need to kind of reduce the dimension of the W towards V being a subset of W. And the second thing that we want to do here is to use interpretable machine learning to, again, kind of balance the trade-off between model performance for very complex black box algorithm and interpretability to really make this model applicable at the bedside. And so that's what we're doing, and we're using some interpretable version of random forest that were developed by colleagues of us at UCSF to come up with an interpretable machine learning algorithm that predicts the individual treatment effects for our septic shock patients. Next slide. So I'm just going to go real quick, and I don't think, unfortunately, I will be able to go into that. But that's kind of the last big topic that we're working on right now, and we're trying to cover humbly, but we're trying to cover the gap between really the need for some prediction and the applicability of this type of tools in practice. And one of the things that we've been working on, as I just mentioned, is interpretability and trying to develop and to work on more interpretable machine learning algorithm. But the other thing that we're also working on at the same time is to really increase the adoption of those approaches by the clinician. And we kind of figured that by including the clinician into the training process, next slide, of a given machine learning algorithm definitely helps not only the algorithm to achieve better performance, and that was the very goal of this paper that was published last year in PNAS about the expert augmented machine learning. So the goal was to show that integrating in this case random forest algorithm at different steps or at different levels of the trees, the expert knowledge was effective in improving the performance of the algorithm. But when talking to clinicians, the interesting part is that by doing so, the clinician feel much more confident in using such an algorithm that again integrated some expert knowledge rather than using something that would be perceived as being more of a black box, even though they're provided with summary measures of the performance of the algorithm. Again, having some sort of active participation into the training process is something that we believe will improve the acceptance and the adoption of those kind of techniques by the clinician. I'm sorry, I have several other slides that go over other application of expert integration into learning processes, but I think I'll stop here and maybe if you can move forward, a couple of slides. Again, I will share my slides and I'm happy to answer any question. But essentially, the visions of the ICU in the future are, either to really augment what essentially augment the type of data that we have access to. And I remember this paper published a couple of years ago that was really kind of thinking outside the box about using genotyping at triage to really better characterize our patients, maybe use some sort of physiological organ analysis and potentially 3D organ reconstruction, which can very well happen. I have no idea, and I'm obviously not an expert of that, but our kind of humble attempt to provide or to move the field I would say a baby step forward is to essentially try to provide the clinician with the best possible predictive and prescriptive tools to potentially transform a little bit the model from, again, a curative model where patients come very sick to the ICU and where it's sometimes extremely difficult to revert the disease process once it's really kind of deeply started, and to transform that into a situation where we would be acting proactively and ahead of time to really prevent some of these very severe complications to happen. That's essentially all I've got. Again, I'm really sorry that I had to rush so fast through the slides, and I'm happy to answer any question or to answer question offline if you have some. Thank you again, Susan.
Romain, thank you so much for exposing us all to that breadth of activity going on with both predictive analytics, real-time predictive analytics, and then moving into causal inference, all to improve patient care and outcomes. We do have one question from the audience, and I encourage people to type in more if you have more. And then I also have a question, but I'll ask the one from the audience first. In case of stroke due to aneurysm rupture, after successful treatment for the stroke, closure of the aneurysm, the human brain acts in a manner that's actually bad for the patient from mortality perspective. So AI/ML mortality, personalized prediction can be wrong in some patients. What to do in such cases?
It's a very, very good question, and there are actually I would say this touches on a large topic of machine learning, or I would say AI-induced bias, or I would say AI perpetuated biases. And that is an example that is based on I would say the physiology and the pathophysiology of a specific process. There are also some other situations where the type of bias that are perpetuated by approaches like this can also be very concerning. One of the things that we're concerned about and we're trying to really address is the disparity or even racial bias that can be induced by some AI algorithm based on the type of data that were used for training, I'm sure you're all aware of the paper published on this very topic in Science. I think 2 or 3 years ago. That was really, I mean, to me, to be honest, it was a real shock when I saw this paper. It was really deeply concerning to me. And one of the things that we and a lot of colleagues of us in different groups are now trying to do when we're identifying situations where, because of the learning process and because of the particular structure of the data that we're using for learning, if we believe that this structure is likely to create a bias, at least that we can understand, then of course it's a red flag. And for the example I just used about disparity, it even led us to push for the creation of a specific center that we're just in the midst of creating now, that will focus on data science for the underserved, to make sure that we're able to really provide the best possible evidence and the best possible type of technology for our underserved patient population. So I'm going a little farther from the question that was just asked, but I feel like this kind of falls under the general I would say concern about algorithmic perpetuated bias.
Thank you. And then I'll ask just one more question. And that is, when you were talking about the interpretability and the acceptance in order for these things to be adopted in practice, the thing I'm wondering about is, have you observed any difference in willingness to accept these things depending on sort of age and when the cohort was first trained? Because kids these days are all using AI and machine learning in their high school assignments and their early college assignments. And so what do you think about the future, about interpretability versus acceptance versus accuracy? And I'll just stop there. I think you get my question.
Yes, absolutely, and that's really also I would say it's a great. I think it's probably the main question currently, I think back I would say probably 20 years ago, the major hurdle for any type of technology like this to really make it to the clinical field was really, I would say, the lack of education of people around that. So that was kind of the first step. So people got a lot more educated during, again, a couple of years ago, with, some sort of education around how to interpret the performance of algorithms. And as you of course all know, I think the way that performance was reported at the time was also misleading. So to some extent, it was kind of a move forward to have people more educated, but to some extent, and I completely include myself in the people who were misled here. I think the even though people were more I would say equipped to appraise the results of studies on AI or machine learning, they were probably not focusing on the good metrics for that. And so this required again some more education, some kind of thinking of the guidelines on how to really evaluate that. But now we're left, I think, in probably the most complicated part of the problem, which is, yes, we probably know relatively well how to evaluate the performance, or what kind of domain within performance is the one that we really want to optimize for a given clinical problem. But we're left off with the situation that I think you're pointing at, Susan, which is really the population-based results versus what really counts in my very hospital, in my very unit, in my very patient population. And I think that's that potential drift in the distribution of the population based on specificities of the population, based on geographical areas, or even based on time, actually, is something that definitely needs to be addressed. And that's also something that we're working on. We're actually collaborating with the FDA on a project like this, whereby we're really kind of at the early stage at this moment, but we're trying to come up with frameworks or procedures that can kind of monitor the performance in an online manner, detect some drift in the performance, and offer some like generic frameworks to actually recalibrate the algorithm within, again, specific population in response to a drift in the performance.
That sounds fascinating. I think we should probably wrap it up here. I want to thank you so much for sharing your expertise with us today, and for pushing these efforts forward and making such a difference in critical care medicine. Thank you very much.
Thank you so much, Susan. Thank you again for the invitation. I really, again, apologize for the technical difficulties. And if anyone has any question that you want to ask me offline, feel free to email me. I'd be more than happy to answer.
And slides and a recording of the talk will be online next week. Okay, thank you, everybody. This is the end.
Thank you.
Goodbye.
Bye.